I am rotating right now in August 2021, right before participating in the match in Hennepin Healthcare. And we saw an article that was very interesting and very good in gastroenterology. It was published in 2016, but he still holds truth for the most part. So, this article, we're gonna do a very short summary of this article, and I already presented this review of literature today in the morning, but I would like to share this with you if it works for you while you're washing dishes or you're in the bathroom or whatever, if you want to see it in your spare time. So I'll try to go through it as quickly as possible. If I'm going too slow, remember you can use the playback speed down right corner and listen to it at 1.5 or 2x. So let's go into this article. So in general, if our first step in cirrhosis is to have a suspicion for it. If we don't think about it, we won't diagnose it. So when we're going through all these different pathophysiology books and clinical semiologic books, one of the most renowned illness to be on these books is cirrhosis. Why is this? It's because you can see all the different manifestations and signs that can be present in a cirrhotic patient. So this image is from AMBOS, the question bank app, which is very good preparation for these steps and boards, and I highly recommend it. So here we have the different manifestations for cirrhosis. Of course, you won't see any patient with all of the manifestations, but take into account that you can see several things. So one of those characteristic findings, for example, which have a low sensitivity but a high specificity is, for example, this Dupuytren contracture and associated palmar erythema. We also have club nails, white nails with ground glass opacity. There is a name for this as well. It's called terry nails, and these terry nails are basically nails that have a different striate nails which look very brittle. So that's one of the things you might find. As well, you can see different manifestations. So take into account that some of these manifestations are due to the estrogen, right? The estrogen hyperestrogenic state that is found in liver disease. So you will have gynecomastia, you will have hypogonadism, amenorrhea, reduced libido. You also have other manifestations that might be secondary to increased portal pressure due to portal hypertension, as you could see with esophageal varices or this caput medusa, which is around your umbilicus, or also hemorrhoids, which will be mainly internal hemorrhoids, because the internal veins in your rectum, the upper internal, have to do or drain to the portal system, and the lower veins will drain to the vena cava. Please let me know if I get any of this incorrect, because we're here to learn. So this isn't meant to be 100% accurate, but I hope that most of what I'm telling you is accurate. So just let me know so I grow with you guys. So we also have the ascites and portal hypertension, and we have other manifestations as seen here. So first, we will be suspicious that the patient has this. Based on what? Based also on the history. So it's not only the physical examination, it's also the history. So we'll talk about the history in a moment. But this was the way the definitive diagnosis was done in the past. So liver biopsies aren't made routinely anymore, but because it doesn't make sense, now we can see the history, the physical exam, and we also can use advanced imaging techniques that weren't there in the past. Now with the ultrasound and the CT exams, we can see different manifestations that altogether might give us a high probability for diagnosing cirrhosis. So we most of the times diagnose patients with cirrhosis without having a definitive diagnosis, meaning we don't have an actual biopsy. But I just wanted to remind some histology. So on this side down below, you can see the normal histology. So here you have a hepatic lobule, and the hepatic lobule, remember that you can't, it's like a hexagonal shape, but you can't like see its edges very easily because the normal liver doesn't have much fibrosis or collagen. So it doesn't have much collagen. That's why you can't see a clear differentiation between lobules. How do you detect what the where the lobule is at? You'll see the portal triads in the apex or in the borders of each lobule, and in the center of all the lobule you'll see the central vein. So remember that let's see that in these portal triads you'll have a bile canaliculi or bile duct, you'll have an artery, and you'll have also a vein. So you'll have the three of them, and in the center the central vein, and that's the usual configuration. So let's see in green. What we are seeing here is I think this in green is how the irrigation or the blood flow goes in the lobule. So from the central vein to the portal triads, and the bile actually flows in the opposite direction from the portal triad to the central vein. Please correct me if I'm wrong, but I'll review this video once I'm finished, and in the comment, in the description below, I'll let you know if I got it incorrect. But there we have three different zones. So these different zones are also manifesting how this is okay, how this patient is being irrigated. So I just figured out I was wrong with what I said, because I remember that zone 1 is the best, has the best irrigation or best blood flow. So zone 2 a little less, and zone 3 is even less perfused. So this would mean that the red line is showing us how the blood flow goes from portal triad to central vein, while the bile actually goes in the opposite direction. So that's the normal lobule. And now let's look at what happens when things go bad. So after that, we'll see that in this patient with cirrhosis, you can see a lot of, look at this. This is collagenous tissue. This is also a fibrosis. This collagen right here shouldn't be here. And you're seeing a lot of collagen here. What is it making? It's making an architectural disarray in this liver. And this disarray is generating all the manifestations, or many of the manifestations of cirrhosis. So here in this image we can see a liver. So this is a biopsy, and in this biopsy you can see how this is nodular. So a famous pathologist called or known as Washington Deceit in YouTube, which I highly recommend. His videos are great, and actually this image is from his videos, and this one too. This one is showing us how we have a nodular liver when we have it in this disease, terminal disease phase known as cirrhosis. So in the past, it was known as nodular, micronodular, and macronodular. But bear in mind that these are just descriptive terms. In the end, if the nodules are small or large, the patient is in the same stage. What is important is to find out what the underlying cause is, so we treat it. So let's move on to a mnemonic for us to remember what are the causes that eventually lead us to cirrhosis. So if you have seen this episode in Netflix for the series called Dirty Money, there is an episode that talks about this car brand VW, and what it mentions is that VW had branded itself in the past or some years ago as highly efficient and not and very friendly with the environment. And actually, many of the numbers that they were saying were rigged, and that didn't hold true. So here we have all this cloud of black cloud VW. So what does this mean? This means that VW happens, and that's the mnemonic for the sake of the argument. So VW happens would mean that there are these different causes. Remember that it's never only one cause for cirrhosis. They may be combined and they might act in synergy in order to worsen those hepatocytes. So we have different causes, but the most common causes are these. So the viral hepatitis are very common. We also have the ethanol or alcohol lesions, and we also have the NASH or non-alcoholic steatohepatitis producing liver cirrhosis, and also the other subgroup in which would be NAFLD, which would be non-alcoholic fatty liver disease. So patients may have several of these acting at the same time and making the progression to cirrhosis even faster. So this autopsy we see here is a shrunken liver, and this shrunken liver is showing us that it is in a very advanced disease state, because what we usually palpate in the abdomen as hepatomegaly is usually a phase before cirrhosis, because when you have cirrhosis, the liver is usually shrunken due to all this fibrosis and scarring, and many times you won't be able to palpate it on physical exam, as you can see here. And on this right side, you can see the hepatocytes, that they are actually, many of them are either sad or dead. So in general, they should be happy, but of course, all these deleterious effects will make them sad. What makes them sad? So there's the theory about the ethos cells, which are the ones in charge of having or storing vitamin A, but when they are exposed to oxidative stress by any of these causes, they will start building up collagen, and this fibrous tissue generates all this architectural disarray with pathophysiologic implications. So the main causes for transplant in patients with cirrhosis are the viral hepatitis and the non-alcoholic steatohepatitis nowadays. So the NASH patients have grown in number due to obesity and all these risk factors that are increasing the rate in which incidence, right, of cirrhosis secondary to NASH. So in the future, probably this will be the greatest cause for orthotopic liver transplantation. We have to take that into account. So let's talk a little about the pathophysiology of what is happening. We have a patient with cirrhosis that develops portal hypertension. Why? Because we have all these cells that are scarred, and since they're scarred, the fluid that should be moving around these hepatocytes in the DISE space, for example, which is interhepatocyte spaces, is affected. So instead of having a space like this between the hepatocytes, there's too much fibrosis, so they're stuck like this, and liquid can't go around them, or the transitate that or the blood can't go around them, or transitate can't go around them. Then it starts building up, and here is where you see stasis. And when you have stasis, this will go back. Backflow of stasis will generate the portal hypertension. When you have portal hypertension, what is the next step? That it is thought that the splanchnic arterial vasodilation might be produced because there is increased generation in this area, like a compensatory generation of nitric oxide. There is also a worsening hyperdynamic circulation and decreased systemic vascular resistance. All this contributes to there being splanchnic arterial vasodilation. So it's strange. You have it isn't flowing. The blood isn't flowing very well around the portal system, and suddenly you actually have vasodilation. Why? Because it's kind of trying to compensate, but it ends up affecting the patient even more. So the patient's body will try to compensate due to there being a reduced effective arterial blood volume. So in general, the patient's LEC or extracellular liquid or fluid will be the same or actually increased. But most of this will be in a third space and won't be actually working. Fluid you could move or pump out through the cardiac output. So this reduced effective arterial blood volume ends up in a patient with hypotension. And once you have hypotension, all these other systems come in, such as the renin, angiotensin, aldosterone system. The sympathetic nervous system kicks in, and the arginine vasopressin system kicks in. What happens? That it becomes a vicious circle, and this vicious circle might just get worse and worse, such as what happens in heart failure. We have to try to stop this vicious circle because it's beneficial at first. But if we let it go on, that's why we'll see several problems. So the patient gets clinically decompensated, and when the patient is clinically decompensated, we'll see that the body is basically attempting to retain volume. So because it's sensing that it doesn't have enough volume, for example, the kidneys are suffering, and that's why you'll see vasoconstriction in the kidneys, because they want to hold all the fluid that passes by, because they have sensed that there is a low pressure and they want to increase the systemic pressure. And that's why you'll get hepatorenal syndrome type 1 and 2. So it's important to differentiate a decompensated cirrhotic of having hepatorenal syndrome, which is actually vasoconstriction and trying to maintain the blood volume, versus intrinsic nephropathy, which would actually be manifested a little differently. And you can differentiate this in your urinary sediment. Remember that a urine sediment, a sodium in urine sediment above 40 is telling you that probably the problem is intrinsic to the kidney. Below 20 means that the kidneys are reabsorbing everything they can, so they're actually functioning well, or they're making their best effort. So this would actually make you think it's more towards hepatorenal. And also take into account that there's an increased risk of bacterial translocation in these patients with decreased opsonic activity. What does this mean? That opsonization and your immune system calling the defense system and telling them, hey, a bacteria just came here and it's sitting here for you. That is affected, because since blood isn't moving very well and it's just sitting down there, a bacteria can get in there and go infect right, your abdomen and become a spontaneous bacterial peritonitis or SBP, and there is no good opsonization, meaning that the bacteria can sit there and do whatever it wants because you're not marking that bacteria to be killed in a swift manner. So the other thing that might happen is also hyponatremia, because these other systems we mentioned right now, a couple of minutes ago, are trying to preserve sodium and water. So they're bringing in reabsorbing sodium, but remember that water follows sodium. So water dilutes the extravascular and intravascular compartment, generating a low sodium in your blood. So all this we should try to stop. So we'll see some of the steps we could take. So what have we seen so far? We already talked about the high index of suspicion for cirrhosis. We have to always take into account risk factors in the history of this patient. Of course, a patient which has been a heavy drinker for 40 years and now has cirrhosis, probably you don't have to work this patient up for autoimmune hepatitis, for Wilson disease, for hemochromatosis, because there's a clear cause. But always take into account that if you have something that might be suspicious for another cause, try to make the workup, because remember that it might be working synergistically with any of the other cause mentioned. So we already talked about the physical exam. Some laboratory exams that are definitively important to check are the liver function test, that will be usually altered to some extent, but you can have a compensated cirrhotic with normal liver function tests. And you can also have a cirrhotic with a mildly reduced platelet count. But the platelets are very specific for cirrhosis, or very sensitive for cirrhosis the lower they are. So if you have a platelet count of 100,000, you might say, okay, this patient is thrombocytopenic, but could this be hematologic or not? And okay, versus a patient that has 30,000 platelets and you don't find any other possible reason. It doesn't seem hematologic. Patient has been a heavy drinker throughout his life. You see caput medusa in his abdomen, distended abdomen. So probably we're heading towards cirrhosis, okay? So suspect cirrhosis. After you suspect it, always bring on the team the gastroenterologist or hepatologist if your center has one, and treat all these different areas. So we do nothing if we cannot educate the patient. So always give education, always talk to the patient, and find with the patient what can be done in order to improve. Also try to improve the patient's lifestyle. So we'll see in a couple slides what to do, and try to stop anything that is generating any harm for the liver. We'll see this in the end about care coordination and screen for reversible causes of cirrhosis, of course, and treatable. Great. So what should we do for lifestyle modification? Okay, we have wasting syndrome in these patients. So these patients are trying to reabsorb all the water they can. So they have the sympathetic nervous system very activated. This leads to a catabolic state that happens throughout the day. And this patient is losing muscle, is starting to enter a sarcopenic phase. That's why this patient isn't your usual patient that can do an intermittent fasting. These patients shouldn't fast, because even the overnight fasting might be deleterious for them. So it is considered that it is a good idea to give these patients several meals a day, and even a meal right before bedtime would work in order for them not to lose muscle, because if you lose muscle in whatever context, you will pay for it, because it usually will make you immunosuppressed and will generate problems along the way. So we don't want the patient losing their muscle. So it is recommended the patient should receive a high protein diet. Recommended is 1 to 1.5 grams per kilogram of dry body weight. Dry body weight is when the patient is well compensated without the ascites. Because if you're calculating this and the patient has 10 liters in his abdomen, you're probably giving more protein than needed. So dry body weight, and give also late evening meals. So if you guys go on the web and check out the different options there are for giving what nutritional recommendations to give, you'll see that there's a lot of websites that will recommend not giving protein or trying to abstain of protein in the diet, because protein might worsen the hepatic encephalopathy due to the protein breakdown and the ammonia and all this. Well, it has been demonstrated that that is not the case, that protein in the diet is well tolerated, and that is actually beneficial, because if not, this patient will lose the protein he actually needs. So another recommendation is in patients with hyponatremia, remember the magic number, but we should start working before this. The magic number is 120. If the patient has hyponatremia, and even more if the sodium is less than 120 millimoles or milliequivalents per liter, this is an independent prognostic risk factor for the patient, and it's a very strong one. What is this telling us? That, yeah, his sympathetic and his renal angiotensin and aldosterone system is overly active, and we have to try to slow this down. So the recommendation is limiting, and even more in a patient that has ascites, limiting the sodium intake to no more than 2,000 milligrams or 2 grams of sodium per day. This isn't easy, because the patient we are accustomed to eating anything that comes in a bag, and a lot of things have sodium. And for example, these chips that were left over from my lunch are super high in sodium chloride. So a patient with cirrhosis can't even see them, because he'll have problems. So we want to limit the sodium intake. So this might be counterintuitive. The sodium is low because the patient is trying to reabsorb sodium, not the other way around. So don't think that sodium is 120, okay, we have to give sodium and improve. No, if you give sodium, you're worsening the prognosis for the patient. So we already talked about many of these different methods of improving the patient's condition. Of course, we have to avoid anything that isn't given by our provider. The patient shouldn't be taking any over-the-counter supplements or herbal supplements or anything that we don't know of, because it might actually be harmful for the patient. Remember that the liver is the one in charge of detoxifying almost anything you ingest. So it's a magic box, and we can't throw in crazy stuff into that magic box, because we don't know what will come out the other end. So we have to monitor blood pressure. We'll see that in a moment. And discontinue harmful medications. Yeah, of course. Okay. So some medications that are important. We have beta blockers. We should give beta blockers in some specific circumstances that I'll mention in the next slide. Which are the helpful beta blockers? They are the non-selective beta blockers. And what do? Well, they reduce the portal pressures. So in whom will they work? In patients with elevated portal pressures and not any cirrhotic, which is well compensated, which doesn't have ascites or high portal pressures. So we'll see that in a second. So it is indicated for primary and secondary prophylaxis of variceal bleeding, and we should discontinue them when we have a patient hypotensive and in any acute and chronic liver failure. But let's look at this window. So I'm going to move this. This is the window of opportunity we have for giving beta blockers in cirrhotic patients. So these windows are closed and shut, so we have to give them specifically in one time frame. When is this? Okay, let's look at this graph. And when we want to give beta blockers is right here, right in this middle phase. When don't we want to give them? When this patient has early cirrhosis and has not very large, enlarged variceal veins or variceal veins around the esophagus. So we can see this with endoscopy. And if the patient doesn't have very enlarged, if they're just mildly dilated, probably it's telling us, or it's a surrogate that portal pressure isn't that elevated. So we won't get anything positive out of giving them, and we'll actually get the side effects from them. So don't give them there. If we move on to the next scenario, so in this scenario, there is more portal hypertension, or there is portal hypertension, and you have variceal veins that are moderately to severely dilated. This is the patient that actually will benefit from beta blockers before being decompensated. Then you have the patient that is going towards decompensation. That's why you have a yellow area. So you have to think about it. Might work, might not work. We'll try it out. The patient still has a good systolic or mean arterial pressure. The kidney function is around the limit of normal. He doesn't have any other organ being injured. So let's try it out, but let's be careful and watchful. Then we have the last subgroup, which is the patient in which you have severe portal hypertension, but you also have kidney disease. The patient is hypotensive. The patient has other manifestations of hemodynamic instability. Do not give beta blockers to these patients because this will lead to a worse mortality. So take into account when you should give the beta blockers. Then let's move on to other medications often prescribed. So you have NSAIDs. Do not give NSAIDs because NSAIDs will just worsen kidney function. We don't want that, and increase bleeding risk. An exception is if the patient has more cardiovascular risk than his liver disease, so he might need low-dose aspirin. But if not, do not give it. What about opiates? Use them with caution because they can worsen the hepatic encephalopathy. Acetaminophen, that has been a myth because it's actually pretty safe for pain management in patients with liver disease. Although it is metabolized in the liver, it has shown that it's very safe, so you can use it. PPIs, do not give it to every patient with cirrhosis because cirrhosis is not synonymous to PPIs. So give PPIs if indicated. If the patient has peptic ulcer disease, if the patient has had a bleed, yes, you can and should give them. If no indication, do not give them. Sedatives. Okay, what about benzodiazepines? So use out the liver ones. You don't want to use the sedatives that are metabolized in the liver. You want to use out the liver. Out is oxazepam, the temazepam, liver is lorazepam. And of these three, which are the two ones that are preferred? These two. So oxazepam and lorazepam. Then we have statins. So we know that statins may decrease NASH may decrease non-alcoholic steatohepatitis, and NAFLD, non-alcoholic fatty liver disease, may decrease the cardiovascular risk. So take them into account, because these are cardiovascular risks that must be treated. And there was a concern about hepatotoxicity. That is a myth. It is very rare. For every million patients, there are only a couple patients, so you don't have to basically measure liver function tests for all these patients, only if the patient is high risk for liver injury. Let's move on to invasive procedures. If you have to plan an intra-abdominal surgery on a patient with cirrhosis, try avoiding doing it while the patient is decompensated, because it increases the mortality a lot. How do you know about the mortality? Well, the MELD score above 14 is a good predictor of mortality at 30 days. If you have to do an endoscopy, it's relatively safe. You can do it. Do not give antibiotic prophylaxis for cirrhotics alone. And the PEG or PEG tube should not, actually it's contraindicated in patients with ascites, because it leads to too many complications. Try to avoid it. What about paracentesis? So if you have a patient with cirrhosis which is worsening, or a newly diagnosed ascites in a cirrhotic, you should tap the fluid. You have two options. Well, of course, even if it's therapeutic or diagnostic, try always to send the minimum exams. You want to see cellularity, you want to see differential, you want to see how many cells, how many red cells, was it traumatic or not. You want to see how many neutrophils, more than 250, you're thinking about SBP, which is spontaneous bacterial peritonitis. And if you have a specific thing in mind, so as for any other marker you might be thinking of, but that's like the basic you want. And also culture the fluid, because you would like sensitivities after you start empiric therapy. So if the patient is diuretic sensitive, the patient will usually be well off with 5 liters removal, and maintain somewhat this a non-distended abdomen if you are sure you can comply with sodium restriction and diuretics. But if you have diuretic refractory, you'll have to remove as much as possible. So if the patient has 10 liters, remove 10 liters, but you have to give albumin, because if not, the patient will enter a hypotensive cardiovascular collapse and might die, and we don't want this. So give albumin if you remove more than 5 liters, give 6 to 8 grams per liter. And in the case of SBP, with high risk of death, remember also to give albumin, and the doses are right here. And as in any infection, when you suspect it, you have to take the lab work and exams promptly. So promptly in patients with when you suspect SBP would be in the first 12 hours. Every hourly delay incurs in 3.3% increase in mortality. What about the prognosis? The risk of death is much more elevated in any cirrhotic than a patient without cirrhosis. So having cirrhosis, even if it's compensated, you have 4.7 times the risk. In the compensated, you have double that, so it's 9.7. And when the patient asks you, what's his life expectancy, you have to answer, I really don't know. It depends on you. It depends on us. If you comply, if you follow all the recommendations, and we are doing the things the best we can, we might be thinking of 10 to 13 years if you don't decompensate. But once you decompensate, this might narrow down to 2 years or even less. So it's important that you abstain from alcohol, because if not, you won't make it past 3 years. It's important that you have a low sodium diet, that you be sure that you are getting that protein supplementation, that when you are feeling or when your family sees you encephalopathic, they know that they have to increase the dosage of lactulose or rifaximin, when choose to add rifaximin, etc. Education, very important. So the economic burden of this disease is very high. The annual US costs, be it direct or indirect, ascend to $12 billion a year. So it's something that has a great toll on the US economy. And other complications. So in any patient with cirrhosis, the 10-year risk for ascites is 1 out of 2 patients, hepatic encephalopathy 1 out of 3, gastrointestinal bleeding 1 out of 4, and hepatocellular carcinoma 1 out of 2. So there's a lot of risks and complications. Even if you're 100% compensated, you eventually will have some complications, so be ready to face them when they come. And death increases after detection of any complication. Of course, this is clear. But take into account that we have to know the quality of life for the patient, and we have to struggle for it. So it's having hepatocellular carcinoma doesn't mean you can give up, doesn't mean you should give up any of the treatments because the patient has hepatocellular carcinoma and cirrhosis, so we can't do anything else for you. No, there are different approaches. There are some palliative care approaches. There is, for example, this procedure with limited hepatocellular carcinoma, which is the TACE procedure, where you try to embolize that place specifically. And usually, since the liver is very well supplied, it will kill off the part you embolize, but what is around it can usually have a decent blood supply. So that might increase the patient life for a year or 5 months, and that may be enough for the patient to be able to have a better end of life and get prepared with anything and everything he or she should get prepared. So yeah, let's take this into account and let's struggle for the patient's wishes. That's very important. So HCC, or hepatocellular carcinoma, we can see it right here in the image, and cirrhosis is its strongest risk factor. That's why every cirrhotic should undergo imaging at least once every 6 months. It could be an ultrasound or it could be a CT scan. Or you could add AFP to the ultrasound. But you should screen these patients at least every 6 months. And take into account that all the risk factors that produce cirrhosis also are risk factors for hepatocellular carcinoma. All these that I am showing right here. So transplantation is good, but it's not perfect. So it doesn't mean that once the patient was transplanted, story of this great burden was over, because many of these patients recur eventually with certain problems of their liver or also obesity. So look at this, that NASH recurs in basically 2 years after transplant, obesity in 17 to 43% at 1 year. So know how to manage your patient, and know that these patients, obese patients, might also benefit, obese or patients with cardiovascular risk, mainly the second one, benefit from GI intervention, for example, the Roux-en-Y and gastric sleeve, I believe, would be another option. So this last point of clinical approach protecting the liver from harm. I'll leave you the slide right here, but we've talked about it already. I just wanted to add maybe that when you have acute GI bleed, there's a high risk for infection. So always cover these patients when it's variceal bleed. Cover these patients with ceftriaxone 1 gram per day per 7 days. And care coordination is extremely important. I cannot stress it enough. Care coordination basically means that you discharge the patient home, but you don't let him leave, and that's it. Bye bye. We'll see you in 6 months from now when we're gonna scan you for hepatocellular carcinoma, and just let us know how you're feeling. No, sir. Care coordination means to communicate with the patient, help the patient out when the patient has to have any appointment done. Have smart scales so we know, okay, I've seen the patient is going up in weight. Could this be that he is accumulating more fluid? Let's call him. This facilitates interaction with healthcare, and all this has lowered mortality, lowered readmission, and decreased expenditures. So it's cost effective. And what about the future? We have to stop this from its roots, not just treat the symptoms once the patient has cirrhosis. We have to stop these cirrhosis from occurring. This is the future, and these are the patients that will actually benefit in the future. So you have to take into account what you're eating. You have to take into account if you're working out or not. You don't want to have this pandemic of NASH with you and eventually cirrhosis and have to deal with this for the rest of your life. So thank you very much, and that was it. I hope it was helpful, and I'm sorry if it wasn't that great of a presentation, but I really wanted to share it, because if I don't share it today, I'm probably not doing it tomorrow. I'm moving on to another topic probably. So let me know any feedback, and hope you liked it. And any update also, please share it in the comment section below. Thank you very much.